punctum, it means that there is a block at the nasolacrimal duct. But if there is lot of turbid fluid or pus coming, means the fluid we injected entered the sac where there is a lot of stagnation. That fluid is coming from the upper punctum. Then you can infer that thing as nasolacrimal duct block. So that is the difference. This syringing inference we should do very carefully to diagnose the condition. Where is the block before attempting the patient for the DCR. And there is another way, another result may come, that is partial block. Part of it is going and patient is feeling the water in his throat, or part is coming out. That is partial MND block. So all these things you should diagnose before surgery. So any doubts or anything in this? I can go for the next topic, that is congenital MND management.
And basically cardiac anesthesiologist. I have just a doubt. Instead of injecting directly to the syringe, needle, use serum, inject little bit direct, use serum and see the exact location, where is the block, how is the block. If suppose some block is there, then you can probe it directly under guidance of the serum, and it is a more diagnostic and therapeutic, and you can get full whole anatomy. It's a blindly, what is your opinion?
I agree with you, sir. That's the most scientific way of diagnosing the exact block, as you said, sir. But usually what happens, sir, these facilities are not available everywhere, and most of the ophthalmologists and ENT surgeons in the peripheral area are not having this. So what I was taught and what I am teaching also, the basic minimum facilities available wherever the practitioners are there, what they can do with the patient coming with a problem of watering from the eye. The first thing we should ask is it only watering, or is there any pus discharge or mucopillar discharge, and how long? Is there any painful situation there, or any abscess is formed there already, and all these things we should ask. Then if there is, after excluding the acute infection part, the first thing we can do is even simpler than this, sir. What I showed is syringing, the thing called syringing. Simpler than that is there procedure. That is called ROPLAS, ROPLAS. That is very interesting term, where regurgitation of pus on pressure of the lacrimal sac. With your thumb or index finger, when you put it over the lacrimal sac area, that is on the medial canthal area, once you gentle pressure, you observe either mucopillar or purulent discharge coming from the lower punctum, upper punctum or both puncta. That's it. You need not go for any other investigation regarding this. You can directly, straight away diagnose the case as nasolacrimal duct block, because the proximal pathway is, tissue pathway is normal. Only the nasolacrimal duct is blocked. That's why the accumulated whatever turbulent fluid in the sac is draining through the upper or lower punctum. So you can straight away take the case for the DCR surgery. You need not do syringing also. Only syringing is required when this ROPLAS is negative. When you put a pressure, nothing is coming out. Patient is complaining of water. So then you should do the syringing, see where is the block. Even after syringing, when you are not able to decide the site of block, then as sir said, we can go for various radiological investigations, and also this diagnosticogram simple dye injection to the punctum, and entire thing will be visualized with a simple X-ray. X-ray also shows there is up to where the dye entered. That way you can easily diagnose most of the cases. Even other sophisticated diagnostic measures are there. Scintigraphy and MRIs and all the things are available. But usually for a common patient we need not go for this. All those things we can do for the repeat cases. When we do surgery, fail, we are not able to decide where is the block, then we can go send these patients for proper diagnosis of that area and then attempt the exact surgery. Okay? So, yes, sir. But usually that facility is not. Suppose a place like this, Nasrapeta, or even in this, Vijayawada also, most of the areas, okay. So they can use the facility as our side and properly diagnose and proceed. But this is what we learned during our times, and I am teaching that. So coming to the congenital nasolacrimal duct block. So what these babies are born with is usually pus discharge at the on the day of birth. But there are so many differential diagnoses for that. Maybe conjunctivitis, congenital or acquired infection to the during the process of birth, and all those gonococcal infections and pneumococcal infections. All these can be easily treated with antibiotic drops and they disappear. But if the watering and discharge persisting even after antibiotic treatment for 3 to 4 months, then you should suspect that there is a nasolacrimal duct block. So what is the treatment at various levels? You can diagnose the case with simple Doppler test, or there are certain things like matting of the lashes. When mother says watering, you are not able to see any water there, but if there is, all the lashes are matted, it shows that there is watering and pus discharge, not at the time of your examination. So you should diagnose like that and then proceed what should be done. That treatment of the congenital NNTO,
Hello?
so it may be bilateral, it may be unilateral, or simple watering or with pus discharge. So congenital NNTO, 5% of the babies are born with this problem. 90% open spontaneously in the first year of life. That is very beautiful thing. You should all remember this point. We need not do any intervention up to 1 year, because this naturally opens up with massage or antibiotic drops will help to clear the infection, and sometimes we need to do probing or very rarely tubing. So here you can see there are certain conditions. There is a swelling in the sac area. This can be lacrimal sac mucocele, and more dangerous conditions also. It can be ammonitocele, encephaloceles, meningoceles. All these things can occur in that area. We should not jump into the conclusion that it is a lacrimal sac mucocele and start treating, or if there is any mucopurulent inflammatory changes, some people will directly do the IND and they will end up with major problems if they don't diagnose. Here, sir, it comes with the role of CT scan and MRI. If such swelling is here, we should not jump into the conclusion that it is only lacrimal sac swelling, and we should not go into the thing. So sometimes we need to diagnose it properly, especially in children like this. So then attempt treating them. A course of antibiotics systemically and locally sometimes will help to heal this thing. If it is not healing, we should do the investigations properly and then do the IND if required, which is only mucopurulent accumulation in the lacrimal sac area. So massage of the lacrimal duct, nasolacrimal duct, and antibiotic drops 4 times a day, and usually it improves by the age of 12 months in 95% of cases. And if there is no improvement, probing at 12 to 18 months. results 90% of cure by first probing and 6 or 7% second probing. If it is not curing you after second or third probing, we should not re-attempt the case. We should keep the case for early DCR surgery. Usually textbook says the earliest DCR surgery under general anesthesia is 4 years or 5 years. But my way of treatment of these patients little differs. These are all textbook advices. But in our Indian scenario, the condition is totally different. A baby is brought with such first discharge even after 6 months or 8 months of massage and antibiotics. I will not ultra small ketamine, 5 minutes procedure, do the probing, relieve the problem to the parents and to the baby, to everybody. For that, we may not continue the massage like that. How many days? Sometimes this massage, if they don't do properly, that will cause a big access there. How many Indian mothers understand the correct way of massage? How many doctors are having time to explain the massage? So they just say massage and say next patient type usual practice. And mother will go and do massage somewhere there and cause the big abscess there. And second thing, nowadays parents are not having that much energies and interest to cure it non-surgical way. So they don't do these things properly. So patient is suffering and the infection can spread to the eye. So early probing I suggested initially in 1994-95 that presented paper early probing. Everybody before 1 year she wants to do the probing. I given proper reasons why I should. Indian scenario is totally different from the Western scenario. There they can wait for 1 year, but not here. Here lot of infections. The lacrimal sac infections can spread to the orbit and cellulitis and losing the sight. Lot of problems. So better to do the simple procedure of probing properly. One probing 95% result. Second probing less than 6% result. Alas. So why to wait for the probing 1 year, 2 years? This is all. I am not following that procedure. And second thing is this massage. How to do it? Put the finger at the medial canthal area over the sac area. Firmly give the pressure posteriorly, then inferiorly, and lightly medially. If mother is doing this massage 3 times a day, 60 to 70% of cases will cure, because we are creating a volume vacuum there. That vacuum is opening the membranous obstruction between the lacrimal sac and the NLD. So usually that clears completely. But if still that membrane is thickened or already bony formation is there, all these cases the massage fails. Then we need to intervene with probing. And proper explanation of this massage is very important, especially doctors. We are not very good at explaining. That's why all these failures are occurring. So this is the lacrimal sac abscess formed already because of bad massage. So coming to the probing, so we again recollect this probing. The anatomy you should recollect 2 millimeters vertical, 8 millimeters horizontal. Either it will end into common caliculi or individual caliculi into the sac. 10 millimeters sac, 12 millimeters MLDO. These measurements are usually there, but there may be anatomical variations. But we should remember this pathway. Otherwise, we cannot bluntly push the probe and cause the false positives. And this is especially for our ENT colleagues, because I don't know what is happening recently, but initially when the endonasal DCRs coming into the practice, most of our ENT colleagues are calling us for identifying the lower punctum, canaliculus, and passing the probe, and all these things. Once we identify, they are making the passages successfully through the endoscopic endonasal DCR. But of late, ENT colleagues also should learn this anatomy. If you are planning to practice endonasal, endoscopic or laser DCRs, but this anatomy should be learned properly. Otherwise, your endonasal DCR will result in a failure because of this problem. This is canalicular injury, canalicular stenosis. This is very, very, very difficult to treat after once this problem occurs, this complication occurs. We need to do bilateral upper end bicanalicular stenting we should do. The stents will not stay there 3 to 4 months. They should stay, especially in children. They remove them by pulling from the nose, and all that is again fail once it, and ultimately results lifelong warping. So better to learn the anatomy properly and attempt the thing. This is how first step is putting the nettleship punctal dilator. This instrument for the postgraduates, this is the name of the instrument is punctal dilator, nettleship punctal dilator. First you pass this, dilate the punctum, dilate the ampulla, and then pass this probe. There are various sizes of the probe. This is Bowman's probes. Bowman probe from 0 to 4 size are there. Initially with 4 size, small size we should start, and gradually dilate this canaliculus. You can start with the lower canaliculus or with the upper canaliculus. Enter the lacrimal sac. So once you enter the lacrimal sac here, you can get 2 types of feeling: hard stop, soft stop. Hard stop means once you touch the, there is a problem at the common canaliculus and lacrimal sac area. So it will result in the soft stop. You will not touch the bone. There is a soft feeling there. So in that case, your probing is going to fail 100%. You stop there and come out. If there is a soft stop. So if there is hard stop means your probe entered the sac, touched this wall of the sac, this medial wall of the sac, and you are touching the bone also behind it. So if you feel the hard stop, then you can proceed with further this thing. Here you can see hard stop means this is one membranous feeling you can get. Bony feeling you get. Soft stop means your canaliculus is dragged here, and it is resulting here this soft stop here. You can see here. So here you should not continue with your probing. This will definitely result in the false passage. So you can proceed here, but not here. So then step is vertical. Go vertically down and enter the NLTO. So these are the instruments usually do Bowman's probes and nettleship punctal dilator. So this is how the probe is passed here to the lower punctum, and here double checking with another probe through the nose. Both metal touch, tick tick sound you can hear. Then you mean that you are proper place. As sir said, these are the blind procedures, but we are doing, and most of the things are we are getting the results properly. We are still following, but you can do it.
Hello, auditorium.
Sufficient way under the visual.
Hello, auditorium.
Hello,
Srinatha madam.
Hello.
Hello,
Madam, we are ready with the case, madam. Patient has been intubated already.
Okay, sir. Okay.
We will do the discussion while we do the external DCR, madam.
Okay, sir.
Okay, sorry to disturb you, madam.
No problem. This probing is over. Only a video should be shown, but later on also we can see.
Okay.
Thank you.
Okay.
I request Dr. M.S. Chaudhary Garu and Raidu Garu to hand over the mementos to.
Sir, చూడ sir.
Now the
workshop on behalf of the AOA branch at Kondaveedu ENT Hospital. Now we are going to the surgical live session.
Sampath.
Hello.
Sampath, I am Dr. Shekhar Reddy.
Yeah, sorry. We are not getting the picture here.
Okay. When you get the picture, kindly inform me.
Yeah. We are good here. I request Dr. P.S.N. Murthy Garu to chair the session and Dr. Parasuram Garu, Chilkurupeta. Please chair the session, sir. Hello, security?
Hello, Sampath. Are you getting video pictures?
No, not yet.
One second.
He is a complete ENT and head surgeon and one of the key person in RMSC cochlear implant program. I will hand over mic to Dr. Krishna Sharda. Sir.
Hello.
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 Yeah, hello.
Yeah. Good morning, everybody. And morning to Dr. P.S.L. Mutiaru, chairperson there, and all the delegates. We have come over from all parts of.
It gives me an immense pleasure and honor to introduce Dr. Krishna Garu, who is a professor and head of the department in Andhra Pradesh and the superintendent of government ENT hospital at Vizag. He is an eminent and soft-spoken teacher. He has good motivational attitude towards undergraduates and postgraduates.
Your picture and we can understand your problem. You have a deviated septum.
Yeah, we have a divided septum here, sir, but reasonably ample space here to working. Yeah, definitely it's a deviated septum, a high deviation can say a bit, but it's not coming in the way luckily. You can manage with this. But if it is really coming in your way, a lot of space, prefer to do a septoplasty first and then go with the endodosia. 4% gelatin and adrenaline, carotenoids, and that gives a very good decongestion effect here. And I can see a nice fit. I see with infiltration there, lot of infiltration of 1% gelatin, 1 in 1 lakh there is of adrenaline. In fact, the bleeding is the infiltration points here, only 3 points you can. One is at the just attachment of the inferior vertebrae, as you can see here. You can appreciate this blanching happening.